Yes, Dr. Soveeta, again, she's a practicing of a neuro-ophthalmologist from Shroff Charity Hospital, and she's going to be talking on decoding unexplained vision loss. On to you, Dr. Soveeta. Yeah. Can you?
Good evening, everybody. Is my screen visible now, ma'am?
Yeah, it is.
It is, but your voice is cracking. Let's hope it continues.
Maybe you switch off your video. Anyway, it's switched off.
Carry on.
Thank you, ma'am, and Team iOS for giving me this opportunity. So I would just brush up on how to go about unexplained vision loss, which is actually defined as decreased BCVA, which cannot be explained by underlying pathology of visual pathways or is out of proportion of the identifiable lesion. Now, why is that important? Because it causes distress and anxiety to patients as well as physicians. And we must differentiate it from functional vision loss by avoiding unnecessary investigations and workups and preventing any loss of wage and additional cost to our patient. So 5 to 12% referring with vision loss to neuro clinic were subsequently diagnosed with medically unexplained functional vision loss. And this functional vision loss is estimated to account for 5% of the general ophthalmology practice. But Scott et al. Also found that 53% of those who were labeled with functional vision loss had concurrent organic pathology. Now, these are the different causes which have been reported in literature, which could cause unexplained vision loss, like bilateral hyperopia, meridional amblyopia, early keratoconus, megomist, Stargardt's cone dystrophy, Mudes, and sometimes isolated foveal hypoplasia. Apart from that, early bilateral optic neuritis, suprasellar tumors, cortical vision loss, monophysitic syndrome, and amblyopia are few of the causes. So we begin with a case of 32 years old male who presented to us with both eyes diminution of vision since 6 years of age, which was bilateral, simultaneous, no photophobia, no nystagmus, BCVA 636, contrast affected, red green deficiency, no significant refractive error, temporal pallor as we see in fundus photographs. And then a field showed some centrocecal scotoma. So we went ahead to do OCT, which was grossly normal RNFL, but GCC was showing thinning. And with temporal disc pallor, central scotoma, GCC loss, we could suspect that these were the differentials. All of the further evaluation showed there was vitamin B folic and for B12 and folic acid was low, and therefore vitamins were prescribed. Toxic, there was no such history. Hereditary, no such history at clinical presentation, and no compressive lesion on MRI. And so a pedigree analysis and genetic evaluation was done. And then this showed that the brother also was affected. Meanwhile, the genetic test showed that the LHO gene, which we commonly test for centrocecal scotoma, bilateral pallor, temporal disc pallor, was negative. So now the younger brother was examined, and history of gradual progression loss was there in early childhood with 624 visual acuity, temporal pallor of both the disc and RP atrophy. And he also carried an old records of cone rod dystrophy. This was a brother who was always accompanying but was never examined. Now, revisiting our patient fundus, we just find that these subtle RP atrophies, which were missed. Now we see that the OCT shows significant RNFL, which was normal, but the GCC is out of proportion. So there should be always a suspicion to correlate the GCC with the RNFL. And a macular OCT now shows some RP irregularities, which was further confirmed in autofluorescence, and the diagnosis was changed to cone rod dystrophy for this patient. So definitely OCT gives us a clue apart from a clinical examination and a field test and routine evaluation of fundus. This was another 71-year-old female who presented with bilateral vision loss in both eyes, hand movement, CF 2 meters. Rest of the evaluation was not applicable as in color and contrast. IOP was normal. These are the fundus which were grossly normal, but it showed a right homonymous hemianopia, and on further imaging, because of this vertical meridian, we could found that there was the left PCA infarct accounting for the vision loss. So imaging is a rescue at certain cases of suspicion when we have no other cause to evaluate what is the vision loss amounting to. A 23-year-old female who presented to us is again both vision loss, gradually progressive, decreased amplitude of pupillary response, temporal pallor or disc pallor. And these were the fields which he had done elsewhere, and he was carrying. He also was diagnosed as bilateral retrobulbar neuritis elsewhere with 3 doses of IVMP given, but the brain reports, the MRI which he carried were normal, and the VP showed P100 latency. So with a differential of many, we ruled out that possibly now it is hereditary optic neuritis. And when a genetic analysis was done, the genetic test was positive for LHON. So since we have a genetic counselor at our end, it is always easy for us to rule out these cases. So a genetic evaluation clinches the diagnosis many cases, and most of these tests also could have been evaluated if you think retrospective. Now, this 13-year-old male child, the vision loss was complained of bilateral diminution of vision since 4 months, but visual acuity was 6.9, no significant refractive error, subtle temporal pallor, but the discs were more affected rather than which did not match with the visual acuity. So, and the fields were more affected. And an OCT was done, which was normal macular OCT, but there was a similar history in our elder brother. And on genetic analysis, we found that this could be Stargardt's, which was again confirmed by autofluorescence. So at times, autofluorescence gives us, and autofluorescence will help us to know that this could be a retinal dystrophy which would have been missed. A 4-year-old child presented to us, male, preterm, but there was slow involuntary eye movement since birth. TAC visual acuity was 1200 and no significant refractive error. The nystagmus was fine, low amplitude. On history of bumping into objects, photophobia, night blindness, querying photophobia was there. On and off parent says he closes his eyes on exposure to bright light or sunlight. At this point, we did not do any further evaluation, but only a ERG, which showed diminution of photopic and photopic response, confirmed the diagnosis or suspicion of bone rod dystrophy. So ERG and that's all helped us to make a diagnosis in such cases. Another 40-year-old female who presented to the comprehensive OPD had senile cataract, very early senile cataract, and 636 was the visual acuity. And there was no further improvement after cataract surgery. This patient was sent to OPD with the same vision post-surgery also. Now, there was no RAPD, color vision not applicable, fundus looked normal, but we did a field with stimulus 5, which shows central cecal scotoma. And on taking history, as we discussed before, the patient was on ATT and he was still on ethambutol. So there was discontinuation of ethambutol. So a clear history is always necessary before doing any surgical intervention. This was the case of toxic optic neuropathy from ethambutol. Another 56-year-old male with both eyes diminution of vision since 3 years, counting fingers half meter, pupils were brisk reaction, anterior segment was normal. So before we evaluate, and since this person was 3 months and other tests could not be done, at that time we didn't, this was a patient who presented to us maybe 3-4 years before. We didn't do an OCT that time, but we were thinking what could be the cause, and for a long time it was considered to be malingering. Then a flash VEP was done, which showed delayed in P100. And based on this flash VEP response, we ordered a MRI, which showed that there was a pituitary mass and was sent to neurosurgeon. So sometimes the flash VEP definitely rules out malingering. This is another 9-year-old female child who presented to us with inward deviation of eyes, blurring of vision, distance and near with binocular diplopia. Now, to remember the background history was she was an emetrope and she has school had changed friends. When we evaluated her, visual acuity was 20/100 and N24, large comitant esotropia 35 to 80 prism diopters, variable myopia and retinoscopy of -4 to -5 with a lead of -4 diopters. Next, we evaluated her, we asked for an atropine. On atropine, she had no significant myopia. And so the cover test was still there. MRI also was normal. So now with this excessive convergence, esotropia, ocular pain with her, she was a case of accommodation spasm and we gave her atropine. So sometimes dynamic retinoscopy and cycloplegic refraction will help us. Ma'am, should I stop here?
Yeah, yes.
These were most of the cases. The other two were still unexplained. I would just show this last slide. This is again unexplained where we had vision loss, but we could not evaluate. So sometimes microtropia, CVI in older children with subnormal vision, cancer-associated and autoimmune retinopathy have also been reported. So recheck visual acuity, retinoscopy, and if mild vision loss changes, one should also evaluate for dry eye or ocular surface problem. Otherwise, the basic test which we know, but to learn or to pinch which test is appropriate for which case would help us evaluate an unexplained vision loss problem. Thank you.
Thank you. Thank you very much, Dr. Soveeta. Wonderful set of cases, and it's just paucity of time. Otherwise, we would have heard it all. Thank you very much. We are not going to take questions for this session, this talk. We'll come back to it if we have time.